All right, so the advisory board, if you don't know, is a membership organization, and Language Access Network is a member of the advisory board. So it's not just kind of me swooping in and occasionally speaking, but it really is a back and forth, and that membership is really important to us. So as we have time today to talk, I know Bruce might kick me off and not have a lot of time for questions. If there's anything you need, if there's anything you want to know, please find me. You'll have my information here, and you can get it through the conference materials. And the advisory board is glad. We have teams of PhDs just running around on hamster wheels back at the office in Washington, D.C. They'll be thrilled to write a white paper for you. So please do let me know if you need anything at all. So let's dive in. The Affordable Care Act has survived this past year its second trip to the Supreme Court. CMS continues to roll out an array of value-based payment models, and now we are all done with the third open enrollment period on the public exchanges, so that's complete. In the private sector, we have health plans and employers that are testing a range of strategies to rein in healthcare spending as well. Some purchasers are betting on healthcare, on population health, I should say. Oh, it just got real sexy in here. By the way, I should say that I'm thrilled that anyone is sitting at the tables. I ordinarily contend with no one sitting in the front. That's normal, but I rarely contend with a lounge in the back. So thank you all for sitting at least intermediately close. Okay, I feel like Barry White should be playing on the background for the rest of the time. So regardless, the complexities that are playing out in the marketplace right now don't really offer a path forward that is necessarily and immediately obvious. And I know everyone in the room does kind of different things, and we're trying to figure out how to best move forward. But I think looking at healthcare in general and really seeing what works for providers and what providers are going through helps us all recognize how to move forward and figure out the best way forward in this new world. So in a lot of ways, providers are being pulled in two very, very different directions at the same time. There's this tension between integrating and unbundling the delivery system. So obviously finding a way to thrive in this new world is no small feat. So over the next half hour or so, I'd like us to discuss some of the biggest market trends in our industry: population health and consumerism. How are they developing in the market? There's a lot of change occurring right now. A lot of things are in flux. So I'd like us to look at the implications of these changes. And of course, as I say, the goal is to figure out how to react to these changes, how to proactively use these changes for your advantage. So with that, because I feel like Bruce won't allow any questions afterward, anything going in make sense to everyone? Any questions before we begin? Okay. So if we'd been having this conversation 10 years ago, this slide I'm showing you right here to start us out would have been very, very good news for hospitals. Pricing is back. Spending is back. It's time to start building again. It's time to start investing. And on the surface, some of that is absolutely true today. Spending has come back. The evidence is fairly clear that the healthcare industry is absolutely coming out of the post-recession downturn. But most of the increase isn't going to hospitals. Some of it comes from coverage expansion, from increased utilization among the newly insured. Mark was talking about some of the newly insured a moment ago. But the majority of this surge actually comes from the prescription drug side, from specialty drugs like Sovaldi, which cost $84,000 for a 12-pill course. So there are increases, but if you actually look on this slide at pricing for hospital services, you can see that for the first time, providers are actually starting to lose out on price. Now, the advisory board and probably all of us have been talking for some time about the end of price growth, but last January, as you can see, was the first time that recorded price growth was actually negative. It's rebounded a bit since then over 2015, but what I think is clear is that steady and predictable, significant price growth is clearly a thing of the past. So the days of living on price and inflation alone are gone. And I think that is most obvious when we look at Medicare. So here on this slide, you can see that the Affordable Care Act, Obamacare, cuts Medicare reimbursement dramatically. Billions of dollars in payment cuts, as you can see there on the left. And the results are pretty drastic. It's not at all unreasonable to expect Medicare pricing to trend toward today's lower Medicaid levels across the next decade. Also, we'll talk about a little bit the sustainable growth rate fix. That's not particularly helping either, at least not on the hospital side, because roughly half of the funds that were allocated to pay for the sustainable growth rate fix and that repeal are going to be on the backs of hospitals in the form of various price cuts. And as you can see on the right, the administration continues to propose additional reductions. The recent budget deal, which was signed into law in last November, requires site-neutral payments. Site-neutral is a buzzword we've been hearing a lot about lately. And that site-neutral plan is going to erode the unique pricing advantage that hospitals have today. So what it means essentially, without getting too deep into it, is there are new lower rates for any outpatient clinics that hospitals build or that hospitals acquire. And their hospitals are grandfathered in before it was signed in November, but anything after that takes effect. And of course, there are no shortage of additional healthcare reform ideas. After all, yesterday was Super Tuesday. We are smack dab in the middle of an election year. We are hearing about a lot of healthcare. We're hearing a lot about healthcare and healthcare reform from both sides of the aisle, Republicans and Democrats. So I think it would be remiss of me not to spend at least a moment on this. I want to be clear though, when I put together this slide, we arranged the leading candidates and probably have to change the pictures eventually as the weeks go forward. But we've arranged the leading candidates on their stances by the ACA. We have not arranged this by their overall political positions. Bernie is on the left though, so let's be perfectly transparent about that. And let's start with Bernie. So Bernie on the left says the ACA doesn't go far enough. And I'm sure you know that he's laid out his plan for a single payer system. Hillary in the center there, she supports the ACA, but she proposes tweaking it a bit, and particularly she's focused on prescription drug costs, partially because of what we just discussed. The Republican field, what's left of them, they all support replace and repeal, as Mark also mentioned. They advocate for increasing consumer choice, allowing health plans to be sold across state lines. So no matter what the specific plan is, that's essentially what the Republicans are talking about. And I think it should be said, Mark, you mentioned it, and you're absolutely right. The likelihood of, even with a Republican win in the White House, the likelihood of a wholesale reversal of the Affordable Care Act is exceedingly unlikely. I think that's important to mention too. But each candidate on both sides of the aisle has their own idea. Trump, of course, is always good for a few good quotes. He promises, if elected, to replace the ACA with something terrific. It's going to be huge. I hope that's the only impression we'll have today. So obviously, over the next few months, we're going to monitor what's happening with the elections. It's exceedingly important, but it's a campaign. And each day we are finding out more and more, and it's coming into sharper focus. But right now it's really conjecture to think about who's going to win, what the changes of that potential president might mean. But regardless of the political outcome in this year, we're already seeing major market changes already underway. And we started just a few minutes ago talking about pricing, but it's not just about changes in pricing. And the story that we're going to talk about is not just about Medicare either. Purchasers of all types are making some very, very tough decisions about how and how much they want to pay for healthcare. So let's look at these payers, and they're really going to break it down and what we'll talk about for the remainder of our time. For its part, on the left, the government seems to be doubling down on its strategy of shifting risk to providers. And I know we've talked about this over the last couple of days. Medicare and at least some Medicaid programs are really putting a stake in the ground, and they're shifting the industry toward population health management. So public payers already set prices, as we well now know, but now they're focused on reducing utilization, which is something fairly new. Employers in the center there of this little Venn diagram, on the other hand, they're figuring out whether they want to stay in the healthcare game at all. They're trying to respond to a whole new set of demands under the ACA. And so they're evaluating a wide range of models for how to deliver health benefits moving forward. And we'll talk about them a little more in particular. On the right there, we have consumers who, let's be perfectly honest, have been historically, at least, nothing more than passive bystanders when it comes to the purchasing mechanics of our industry. So consumers now are taking, or in some ways being forced to take, a far more active, financially exposed position. So more and more Americans are making their own decisions about how they want to consume healthcare, and they're also shopping for coverage for individual episodes. So they're shopping for care and they're shopping for insurance. Now these trends, they're not unrelated, right? That's why we have them in that kind of Venn diagram there. But they're not exactly one cohesive trend either. So to craft a reliable strategy moving forward, understanding what's happening in this universe, we need to understand how these seemingly different trends actually do fit together. So let's take a closer look at how each of these purchaser groups are changing their motivations and look how their behaviors are shifting. And I think we have to start with Medicare, because it's already the biggest payer. It's only going to get bigger. Even if everything else I tell you is wrong, I don't think it is, but even if that's the case, this is a fact that's incontrovertible, and it was mentioned a couple of times this morning and throughout the week. The population is aging. And there is no longer any doubt that Medicare is absolutely moving toward population health. A year ago, January, Secretary Burwell announced an ambitious goal of half of all Medicare payments to be in the form of alternative payments, like bundled payments, like shared savings, or indeed full capitation by 2018. Now, I don't know about you, but I'm already putting weekend plans in my calendar for 2018. That is really, really soon and around the corner there. Also, a full 90% of any remaining fee-for-service Medicare payments are to be transitioned to pay-for-performance models in that same time frame by 2018. And you look at the quote at the bottom of the page here. I wanted to show you this. It's from the New England Journal of Medicine from a September issue. It was a perspectives piece. So senior CMS staff commented on the recent ACO results. And we're going to not talk about too much of that today, but we'll talk about a little bit. And basically it says, don't compare ACO earnings with what they could earn in today's economics. Rather, compare them with what you could expect to earn in the future if you don't participate. I said that was a perspectives piece, not so much a perspective as it is a warning shot across the bow. CMS is not just tweaking new payment models to make them more attractive. I think it is very safe to assume at this point that they are eroding the fee-for-service model. So providers are being both pushed and pulled toward risk. The transition to risk is both underway and it's accelerating. Health and Human Services, as I said, made this announcement last January. Congress added its 2 cents in April, as it usually does, and they made payment transformation very real for physicians in particular. And without getting too deep into the weeds here, let's talk a little bit of what we're seeing here. I mentioned it before, the standard growth rate replacement. With the SGR replacement, physicians are at something of a crossroads between pay-for-performance and alternative payments. And it's because the SGR fix creates 2 new tracks that you can see here, 1 and 2 on the left. And physicians have to choose between them. And the first track is called the Merit-Based Incentive Payment System, or MIPS. By the way, I'm convinced that there's someone at CMS whose job it is to take a keyboard and just put their elbow on it and come up with all these acronyms. We have plenty of them, so forgive me if you can't keep them straight. I have a hard time myself. So MIPS, which is a pretty good one, I think it's kind of cute. Medicare brings together all 4 of the physician-oriented pay-for-performance reimbursement programs with MIPS, and it consolidates them into one single program. So starting in 2019, physicians in the MIPS track are going to be subject to a range of penalties, but also to rewards. So they're looking at downward adjustments of up to 9% and upward adjustments of up to 27%. That second box there, the alternative payment models, this is the APM track. This offers incentives for physicians to move into downside risk models. So physicians who choose to convert a large share of their reimbursement to an accountable care organization like payment models are going to earn a 5% payment bump, and this is important, they're going to be exempt from the MIPS performance requirements. So this is an attempt here by Medicare not only to tie payment to value, but also to nudge providers toward ACO-like models. And those nudges are getting ever more nudgier. It really is happening fast and furious, because we can't forget about the mandatory payment reforms affecting all acute care hospitals, the value-based purchasing program, the readmissions reduction program, the hospital-acquired conditions program. So without getting too deep into there, I think we should pivot here and look a little bit at what's happening exactly with bundled payment models. So providers across the country have been signing up for the Bundled Payments for Care Improvement Initiative, another one of those acronyms, BPCI. BPCI offers 4 different bundled payment options. And right now, it's Medicare's largest voluntary payment program. Now, participation numbers in the program have fluctuated, but right now, there's more than 1,500 providers currently in BPCI. And what's interesting is that it's not hospitals participating. More than 70% of current participants are either post-acute care providers or their physician groups. So they're recognizing that the largest opportunity to reduce episode spending, at least from Medicare's perspective, is after the patient leaves the hospital. So early results in BPCI have been very promising, although the results are limited right now because CMS has only issued one evaluation report. It seems, though, that providers in BPCI are shifting to post-acute utilization from higher-cost SNFs, skilled nursing facilities, to low-cost home health. And again, certainly we're talking about telemedicine and telehealth. The move toward everyone in the home is certainly striking. And you can see on the bottom there for orthopedic cases, they're saving nearly $4,000 per episode. So based on these initial results, CMS has already decided to double down on bundling for orthopedic procedures. This next slide shows us CMS's latest proposal to mandate bundled payments for joint replacement in episodes in 67 markets across the country, and they are the biggest 67 markets. So unlike BPCI, which is voluntary, as I mentioned, the comprehensive care for joint replacement model, well, that is mandatory. CJR launches this year, as you can see on the right, on April 1st, focuses on 2 procedures, total hip and total knee. That's it. And it's a very big deal, because I said it was the large markets and it's mandatory. Roughly 20% of all of America's lower joint replacements are going to be covered by CJR. So what CJR does is it creates a single episode price that starts in the inpatient admissions and then extends 90 days post-discharge. So previously, bundled payments were an option on the table, but they were never mandated. And it really does look like that's changing. And this is important because if these programs we're talking about are successful, you can absolutely bet that we're going to see other mandatory bundled payment programs. Now, like I said, we're kind of rushing through a lot of information here today, and I hope not rushing too fast. We don't really have time to dive into the details of every risk program. We could spend just an hour and a half talking about ACO models and accountable care organizations in general. We're not going to do that, but I do want to take a moment, I think, to look at Medicare Advantage, Medicare Part C, because there's already a lot of risk-based payment in Medicare Advantage, which has long been an attractive market segment for those providers who are willing to form a health plan, who are willing to take on insurance risk. And the Medicare Advantage program has been growing fast and furious. You can see here on the left that Medicare Advantage now accounts for 1/3 of all Medicare beneficiaries. And about 1/4 of new beneficiaries chose MA over traditional Medicare. Now, with traditional Medicare, patients had one option for coverage. But with Medicare Advantage, not only are providers taking on risk, consumers can choose from a wide variety of insurers. They have options. They can choose on their individual requirements, their individual desires. This is an individually driven retail market. Now, we've only taken a glancing look, really, at the government section and Medicare at large. We're already talking about a lot of change, a lot of options. And so what I want to show you here on this slide is really laying it all out in one place. And you can see how CMS is really starting to fill in the gaps on the continuum toward greater risk. So with mandatory pay-for-performance and programs like the Readmissions Reduction Program, all providers are now de facto at risk for Medicare dollars. So the message from Medicare is perfectly clear. Fewer dollars, more risk. And again, we won't get too deep into it, but Medicare, of course, is not the only payer on the public side. I do want to talk just briefly about what's happening with Medicaid. The big news on this front is Medicaid expansion. In January, Louisiana became the most recent state to expand eligibility. There are now 31 states participating, as well as the District of Columbia. The president is proposing new incentives to sway the remaining 19 states. And Medicaid expansion has been largely good news for the provider industry because in states where Medicaid expanded, hospitals are seeing increased utilization and, of course, improved financial outcomes. And even in those states that didn't expand, we've seen increases in Medicaid enrollment and then consequently increases in Medicaid spending. So that increased spending means that pretty much every state is scrambling to figure out how to budget Medicaid spending moving forward. And it's a huge line item for them, so it's a very big deal. 39 states have taken the strategy of signing contracts with managed care companies. So that's basically just throwing the keys to insurance companies. Not the worst thing in the world, but the bad news for providers is that when they do that, it usually translates to price cuts. We're not going to dive too deep into it, but there are other states that are taking a different approach. You can see some examples of here: Oregon, Colorado, and Minnesota. I won't go too deep into it now. But when the risk is put in the hands of the providers rather than an insurance company, it's yet another opportunity to act as a population health manager, and Oregon has had some particularly good results there. So you can probably sense, without getting too deep into it, where this story is shaping up to look like for Medicaid. It's rather similar to Medicare. We're talking about fewer dollars, more risk, although there's going to be more variability by state and certainly more variability by market. Okay, that's the public side of the equation. What's happening with the commercial world? What's happening with consumers? What's happening with employers? Well, the story of commercial insurance is a story of employers. So employers are increasingly frustrated with rising premiums. They're wary of the looming Cadillac tax, which was originally scheduled to take effect in 2018. Now it's been delayed to at least 2020 because people on both sides of the aisle are not thrilled with its implications. The Cadillac tax, if you don't know, threatens to penalize almost all employers if benefit costs go unchecked. So basically, employers have to pay a 40% tax on the excess value of any plan exceeding $10,200 for an individual, $27,500 for families. And there are a lot of employers out there who are going to have to pay this tax in the next few years if they don't adjust their benefit strategy. But the Cadillac tax is not the only thing that is worrying employers, though. Frankly, and I alluded to this before, employers are fed up with health benefits. And it's not hard to understand why. It's a constant headache. It's hugely complex. Even those of us who are in healthcare have a hard time dealing with it and can't wrap our heads around it. Costs just keep spiraling up and up and up. So across the board, employers are looking for better solutions, even if the Cadillac tax is ultimately repealed. So employers find themselves at a philosophical crossroads. So they're heading in one of three directions they can see here on this continuum. First, on the left, you have the activist strategy. So these are employers who want to or need to stay in the health benefits game because they want to stay competitive in the labor market. It's been presumed since World War II in America that your employer gives you your health insurance. There are a lot of employers out there who are not prepared or not ready for that change, and they feel like to get great talent, they need to offer health insurance. So the activists are absolutely going to continue offering it, but they are going to be a very hands-on purchaser. They're going to be very active, and they're going to pay a lot of attention to exactly what it is they're buying. In the center there, you have this second group of employers. They're happy to offer health benefits, but they're not so gung-ho about it, and they don't really want to get too involved in the process. So this is the employer who would rather delegate that responsibility to someone else. They're going to outsource their health benefits to a third party, and they're going to place more necessarily of the decision-making process and the burden directly on the employee. So the private exchanges are the best reflection of this approach. Then, of course, on the right, the third category of employers who just want to drop coverage altogether, particularly now that they know the public exchange can provide affordable options for their employees. There's someplace to land. We call these, of course, abdicators on the right there. So let's start very quickly by taking a look at the activist employers. So we see the percentage of self-funding continue to rise, even among small firms who are banding together and using their size to kind of work together. And they're all kind of continuing to lean on a fairly familiar crutch, which is shifting the risk to employees through high deductibles, which we'll check out, which we'll look at more in a few moments. But of course, self-funding is only one way to go about it. The active approach of employers takes many forms. So let's look at that for a moment, because some employers, on the top there of this slide, they're following the government's lead. They're placing bets on care coordination, on care management, integrated networks. These employers are attracted to, or at least they're open to the idea of a one-stop shop solution. So they're looking at exclusive or narrow network arrangements with a comprehensive population health manager. Others, though, on the bottom, those three right there, they're focusing on smart choices at the point of care rather than wholesale decisions about network design. So instead of choosing a preferred partner. They'd rather maintain their open networks and find ways then to steer their employees to the highest value provider within that broad network. And there are a lot of ways that our places are doing that. You can notice what this approach does, though. It tries to unbundle the comprehensive value proposition that systems that pitch exclusive contracts are making. It's essentially rejecting that top there, rejecting wholesale value in favor of retail choice. So let's look for a moment why the wholesale proposition, which seems like a foregone conclusion, isn't always catching on. Some health systems and some employers have struck these narrow network exclusive deals. And this is just an example from New Mexico. It's Intel outside of Albuquerque, New Mexico, in Rio Rancho, where they make a lot of their silicon. They have a narrow network partner in Presbyterian Healthcare Services. They've managed to improve quality of care. They deliver against some fantastic access standards. They generate incredible employee satisfaction ratings. They haven't quite reduced the cost trend yet, but they're very bullish on it. Intel expects to save between $8 and $10 million in the first 5 years of this program. They're almost through with that. And what's the upside for Presbyterian? 5,400 covered lives in a narrow network. These lives are not going anywhere else. So both sides remain very optimistic. In fact, they've replicated that model that you saw here in New Mexico in their employee base in Oregon. They have contracts with Providence, with Kaiser. We're hearing about Boeing doing similar things. There's an interesting example of Roper St. Francis making a deal in South Carolina. So there are these handful of innovators in employer accountable care organization arrangements. And they seem to be expanding their efforts, the ones that are doing it. But look who we're talking about here. Boeing, Intel. These are big, big companies. These are behemoths. Other than Boeing, other than Intel, who's in this camp? And the truth is, so far, hardly anybody. It's far more common, what we're hearing at the advisory board, that organizations who are really struggling to sell an ACO arrangement to employers. And it comes down to a couple of things. So let's look here for a second, because apart from the fact that many markets don't have the Boeings, the Intels, those huge, large, sophisticated employers, you're also bypassing some pretty entrenched and important middlemen there who are not going to be thrilled about this. Insurers, brokers. These are constituencies that want to maintain their close relationships. And in fact, even when we're looking at this model here with Boeing, they relied very heavily on their broker relationships to put together these ACO contracts. Also remember, parties on all sides are going to be very wary of unproven models. So the market's immaturity becomes self-reinforcing. And of course, the skepticism runs very, very deep, because as much as a provider might like to sell their ACO as the right tool for any job, a lot of employers are looking at it and they say, you know what, I don't really believe that you have all the best doctors in the market. This is not best in class everything, and I don't really think the quality and cost of care is consistent. So what they're doing, rather than putting all their eggs in one basket and saying like, oh shucks, something good, something bad, and also, by the way, provoking a fairly difficult conversation with their employees about restricting choice for their workforce, employers are rather picking and choosing from across the market. They're happy to send their employees to providers for services where they think they excel, but they're going to look elsewhere for services where they don't. And this is where we have these independent referral services stepping in to enable this unbundling. These are the new middlemen, these network assemblers. They're coming in, they're helping steer traffic for employers. And there's many, many of them. We could profile any number of them. We don't have time to get them in today. But again, if you'd like to know more about these independent referral services who have realized that employers and consumers would rather maintain their broad choice at their network level and then cherry pick from across that network, depending on which kind of care they need. If you want any more information on that, please do email me and I can share those slides with you. Okay, so when it comes to, let's look at the private exchanges for a moment, because when it comes to enrollment on the private exchanges, there's something of a slower ramp up than was originally projected. And you can see there those dotted lines were what the projection originally was, and now the red and gray ones are what happened and what's actually the projection. You can still see, though, by 2018, these are Accenture numbers. They're projecting that 40 million people are going to be involved in the private exchanges. And there are some signs that things are moving forward. Starwood, which is now part of Marriott, of course, they're in a private exchange. Time Inc., Sears. We're seeing a lot of the newer exchange operators hit their stride, rack up pretty impressive enrollment numbers. But I do think, without talking too much about the private exchanges, there are a couple of things that need to happen across the next few years if we're going to get anywhere close to the 40 million number that Accenture is still projecting there. So I think if we're going to get anywhere close to these projections, as I say, the thing that's important is we're going to have to provide concrete evidence of these exchanges to keep costs reliably low. We're going to need also to see more employers who are willing to be the first one out there, to step forward and be the first movers in their industry. So again, we don't have too much time to get into it. I feel like I'm giving the private exchanges a bit of a short shrift. But regardless of what happens with the private insurance exchanges, we can't forget about what happens on the public exchanges, which were formed by the ACA. They're already reshaping the insurance market. So we've talked about two strategies very quickly that employers can use to rein in healthcare spending: the activators, the delegators. Those third option, the abdicators, that's going to also take us to our third group of purchasers, that last group, that final group, the consumers. So as employers exit the health insurance game, what they're doing is they're turning employees into individual health insurance shoppers who are buying on the public exchanges. So as I said, we've now completed 3 open enrollment periods, and despite the undeniably disastrous rollout of healthcare.gov, if we all remember that unmitigated debacle, despite that, the insurance exchanges seem to be working. And looking at the results so far and the expectations for the rest of the year, we notice a common theme begin to emerge. So you can look on this slide here, and there's a lot, we can unpack this for a long time, but enrollment peaks at the end of each enrollment year, and that's followed by some drop-off across the year. For 2016, 12.7 million individuals selected plans during open enrollment. And as you can see, the administration, that 10 million number there, expects roughly 10 million are going to maintain that coverage through the year. And that would be up from the 8 million who maintained coverage at the end of 2015. Also, leading up to each open enrollment period, there's been speculation about how premiums are going to change. And once again, this year, we're seeing premium adjustments all over the place. Nationwide, you can see the red little tick there on this schematic of all the states. But nationwide, the benchmark silver plans offered in major cities has increased 10%. But it's really wildly all over the place. Even within a given state, there's wide price variation. One insurer might lower, one insurer might raise. We're really looking at competition in action in here. And I think there's one thing to remember about these rate increases, though. Just because an insurer increases the benchmark silver plan premium does not mean that consumers are always going to pay more. Because the amount anyone receiving a subsidy pays for the benchmark plan is based on their income. So it's not based necessarily on the sticker price. The federal government pays that balance in the form of subsidies. So suffice it to say, health plans are still very much trying to figure out how to price plans for the public exchanges, or in some cases, whether to offer plans at all. I think it's important to mention, because I'm sure everybody's heard about it, after experiencing big losses last year, one of the nation's largest insurers, United, is threatening to leave the exchanges altogether. We'll see if that actually follow through with that for 2017, but their announcement has certainly garnered attention. And United is not the only insurer facing uncertainty right now. More than half of the consumer-operated and oriented plans, these so-called co-op plans, have shut down. And the insurers that are remaining in the exchanges are continuing to evolve their strategies. In Texas, for example, Blue Cross Blue Shield dropped its PPO networks from the individual markets altogether, both on and off the public exchanges. So health plans are trying to adapt to a far more fluid marketplace. You might recall that there was a lot of talk in the first 2 years about the possibility of inertia setting in. It was new. Consumers would shop around for their plan in year 1, but they'd get sick of it and they'd just simply stick in a plan, and they would get stuck with large increases year after year. But probably the biggest surprise coming out of the open enrollment period is just how actively consumers are shopping. We've now seen 2 rounds of repeat customers come back, and they're getting more and more active. For 2016, 43%, as you can see, of repeat customers switched plans, well up from 2015, which also saw more switching than expected. And the number on the left-hand side there, 70% of repeat customers this year came back to at least take a look at their options. And remember, this is all in spite of automatic re-enrollment. So basically what we're seeing is that when there's money at stake, people act like consumers. They shop around. And in this marketplace, at least, as with most others, price continues to be the primary motivator. People continue to select the lower premium silver or bronze plans in overwhelming numbers. And they continue to cite price as their primary decision factor. So given this shopping behavior, insurance companies, if they're sticking around, understand that they have to design premium competitive plans. And those who do stick around continue to bet on narrow networks. And you can see here that during the second open enrollment period, narrow networks typically enjoyed a 15 to 23% premium advantage over broad networks. So it's becoming increasingly hard, as I say, to design price competitive PPO products. I already mentioned the Texas example, but Florida this year as well, there wasn't a single PPO plan offered on the exchange. Of course, narrow networks aren't the only lever that insurers can pull to offer more competitive premiums in the price-sensitive market. The other thing they can do is benefit design. The higher deductible, the lower the premium. The more that a consumer is willing to take on out-of-pocket cost-wise, the lower the upfront cost would be. So the question about this, though, is do consumers really know what they're getting into? And we're running out of time a little bit, and I want to make sure you all get out of here in time. So I'm going to run through a couple things very, very quickly about this. But you can see in this slide that in general, consumers are quite satisfied. I will say this, though. Are these numbers going to hold when they find out what it really means to have a $5,000 deductible, to have a $6,250 deductible? It seems like they're happy, but the truth is they haven't really experienced what it means to have that $5,000 deductible. Most patients, most consumers do not have the cash on hand to cover these kinds of deductibles that they're electing. And let me be perfectly clear about that. 35% of American households do not have $2,000 available in an emergency for a medical procedure. They just do not have it. So you have a couple of things happening here. They could stop consuming care altogether, which of course is problematic in a fee-for-service world, but it's also problematic in a population health world because you want them to check that mole that will be a $50 copay to get rid of when it's early, but if it extends, then suddenly it's a major, major issue. The other thing, though, is that patients become price-sensitive shoppers because, okay, well, I need to go to the dermatologist this year. Well, $5,000 deductible, it's out of my pocket. I'm going to shop around. And what's the first thing you do when you shop around? What's the first thing you do if you shop around for anything these days? Cost. And where do you go to look for your cost? On the internet. You Google it. You go straight online, and we're seeing a lot of metrics that show us people are going online looking for pricing tools. Unfortunately, right now they're falling short, but we are seeing a lot of players catch up to the game. Blue Cross Blue Shield of North Carolina has an interesting example. Guru.com is quite fascinating. So I'm going to use a few moments here just to wrap up. Bruce won't be too mad at me. Like I said, we went through a lot of information over the last 30 minutes, and I know it can be a lot to talk about. We are, as this slide says, facing a dizzying array of cost control effects. There is no denying that this world is one of increasing complexity. We are facing a cacophony of cost savings, risk shifting, performance managing strategies from all different stakeholders, and they are buying providers' products, they are buying providers' services. So just here to kind of wrap everything up, you have the outside there, the government that we looked at pushing toward population health and risk, clearly, employers who are budgeting healthcare any way they can, and consumers who are demonstrating that even healthcare has a price. They are purchasing higher deductible health plans, they're shopping around for care, and they're trading narrow networks for those lower premiums they want. So the challenge that providers face today is how to sort through all of this noise. And of course, there are a couple of slides here to really define what that noise is, betting on a wholesale value proposition versus the unbundling of that system, which I talked about. It is not a choice, though. It's not an either-or proposition. The fact is that providers don't get to choose between one side or the other of this tension. Both are going to happen. So what hospitals and health systems need to do is find a strategy that won't break when pulled in direction. It's kind of the silly putty strategy here. And here, of course, are some strategies for resolving that tension. I think the most important for us in the last few moments is to remember the consumer experience. Providers have to deliver an exceptional consumer experience. And I think this is particularly important for all of us in this room because they want to build lasting patient relationships. Patients have to actively want to choose a provider. And they're using all kinds of telemedicine platforms, using all kinds of new innovative ways of thinking to make that relationship stick. That's the key to winning under both integration and unbundling. So the reality is that in a fluid retail market that we're discussing here, nothing is permanent. Someone might choose your network at the beginning of the year, but then every open enrollment period, as you can see, they can go, they can change their minds, which means that every interaction that you have with a patient is an opportunity to reinforce that relationship through positive experience, through positive outcomes, or it is a very clear way to alienate them. So put another way, we're all very much in the renewals business now. So to be positioned to deliver the value that the market seeks, providers have to meet the baseline requirements on top there of cost and access, and then be able to differentiate on quality and service. So responding to both those integration and unbundling themes. That's the provider challenge. A lot of moving parts, I know, but I think today's fundamental challenge is to recognize the problems that the consumer is facing and solve it for them. A consumer-centric model is certainly, above all else, going to be the winning formula moving forward.